Good afternoon and welcome to Department of Medicine Grand Rounds. We are there we go. We are grateful as always to Tim Gill and the Gill Foundation for supporting this annual lecture series. The foundation supports HIV research and treatment and prevention efforts, and it currently focuses much effort very successfully on securing nationwide civil rights for LGBTQ Americans. That is Tim Gill receiving the Presidential Medal of Honor, I think last year from President Biden for all his work in this area and the foundation's work. And so it's my great pleasure to introduce Dr. Susan Buchbinder as the 2025 Tim Gill Visiting Professor. She graduated from UCSF School of Medicine in 1985. She did her internal medicine residency there in the late 1980s. As you all know, that was a very trying time before the advent of effective ART, when we were in a very dire situation and very challenging situation with, to say the least, with HIV. She has stayed on the faculty there since. She's now primarily appointed at the San Francisco Department of Public Health as director of the Bridge HIV program, and she is affiliated as a clinical professor of medicine and epidemiology at UCSF. And so over the past 3 decades, Susan has been very much at the forefront of HIV prevention research. She has led landmark clinical trials of vaccines, PrEP, and other prevention strategies, while also being very much central in shaping the public health effort for HIV programs in San Francisco and indeed globally. She's held key leadership positions in the HIV Vaccine Trials Network and the HIV Prevention Trials Network. She's led high-capacity U.S. sites for enrolling diverse cohorts of HIV-negative at-risk persons. And she co-founded the San Francisco Getting to Zero Consortium, which brings together over 300 partners working to eliminate new HIV infections. Last night, she met with members of the Front Range HIV community, patients, and got a lot of great questions, very well received, and answered a lot of great questions. This morning, she spoke to our division about STD PrEP. I should also mention that she's an author on over 350 articles in peer-reviewed journals. And she's really consistently pushed this field forward, from defining HIV risk and prevention in diverse populations to piloting innovative health tools and pharmacy-based PrEP delivery. She's also won UCSF awards for clinical excellence and excellence in teaching. So please join me in welcoming Dr. Susan Buchbinder, who will speak on the leading edge of HIV prevention.
Thanks so much, Eric. I'm going to be talking about, I can't seem to get the, let's try the cursor. I'm going to be talking about the leading edge of HIV prevention. And before I start, I want to invite you all to scan here for CME credit. And we'll show this slide again at the end so that if you don't get it right now, we can, you'll be able to get it at the end of the talk. These are my disclosures. I have received grant money and/or study product from Gilead Sciences, GSK, Merck, and ViiV Healthcare. So I've divided this talk into 5 sections. The first part is about in whom are new infections in the US and in Denver occurring, because that's really where we need to focus our activities. I'll talk about something called U equals U. We'll then spend most of the time talking about pre-exposure prophylaxis. We'll spend a little bit of time talking about post-exposure prophylaxis, or PEP, and then we'll talk about monoclonal antibodies and vaccines. So this is some data from the US in 2022, there were 31,800 estimated new HIV infections in the US during that time. 2/3 are in men who have sex with men, 22% are in people who inject drugs, and 22% are in heterosexuals, and 7% in people who inject drugs. The challenge is that our goal under the Ending the HIV Epidemic was to get down to 9,300 new diagnoses by 2025, and that would require a 71% decline, despite only having a 22% decline over a 10-year period. So we have a lot of work ahead of us, including that we want to divide that again by another 2/3 by 2030. So those are our goals. And you can see for men who have sex with men, people at heterosexual risk, and people who inject drugs, there have been very modest declines over the last 5 years. So we have to focus some of our efforts in the South that account for nearly half of new HIV infections, although 23% do occur in the Western United States. And we know that men who have sex with men, again, make up about 2/3, but Hispanic or Latino men who have sex with men make up the largest total number of new diagnoses, and unfortunately, those have actually increased over the last 4 years. The next group are Black men who have sex with men, and they have the highest diagnosis rate per 100,000 population, and that number has been stable, which is not a good thing because we want to be driving it down. Then come white men who have sex with men, where we have driven down new infections, and then Black women at heterosexual risk. They have the highest number of new diagnoses among heterosexuals, and those numbers also have been stable over time. So again, we've got a lot of work cut out for us. And among transgender people, you can see that we have these same racial and ethnic disparities, with Black African Americans and Latinos making up a disproportionate number of new diagnoses. So these are the number of new diagnoses in Denver over the last 10 years. And what you can see is the numbers really haven't gone down. They're actually a little bit higher than they were 10 years ago. Now, I understand that the population of Denver has grown quite a bit, so that may be that the number per 1,000 population is declining, but again, there's more work to be done here. And if you look at the prevalence of HIV in Denver, you can see that it's actually somewhat higher than in Colorado or the West or the United States, meaning you just have more people here living with HIV, which makes prevention all that more important. The new diagnosis rate, however, is a little bit higher than it is in Colorado. This is per 100,000 population. And a bit lower than in the West overall and in the United States overall. What I wanted to do was then compare new diagnoses to the size of the general population so that you can see where the disparities are. And if you see the black, in the blue bars are the new diagnoses, and in the red bars are that subgroup's proportion in the general population. And you can see that for both Black and Latino individuals, you have an excess number of new diagnoses, and Latinos make up almost half of new diagnoses in Denver. In terms of age, you can see that the 2/3 are 25 to 44 years of age, but we don't want to forget the other ends of the spectrum, where almost 16% are 13 to 24-year-olds, and 6% are 60 years of age or older. Men make up 86% of new diagnoses. Almost 3/4 are men who have sex with men, and another 5% are men who have sex with men who also inject drugs. And if you look at women, who make up 14% of new diagnoses, 45% are heterosexual, acquired HIV through what was presumed to be heterosexual risk, about 2.5-fold higher than people who inject drugs, but there's a large group of people for whom the route of infection is not known. I wanted to just show you what we've been doing in San Francisco in contrast, just because what we did was we pulled together a consortium of over 300 members of academia, community-based organizations, the health department, the government, industry, private providers, for an effort that we call Getting to Zero San Francisco. And you can see that in our pre-Getting to Zero days, we declined by about 28% in 7 years. But post-Getting to Zero, 67% decline over 11 years. And that's compared with 22% decline in the US over that period of time. So I do think that bringing different groups together can really help drive down HIV infection rates. So let's talk next about U equals U, and that means undetectable equals untransmittable. And this is a really important concept that an individual with an undetectable HIV viral load, which is defined as a a viral load of less than 200 copies per ml, is incapable of transmitting their HIV infection to sexual partners. And that also reduces the risk, but doesn't completely eliminate it from mother to child transmission or from parenteral exposures. And these are some data that just show in numerous studies in which there were serodiscordant couples and the positive partner was undetectable or had a viral load of less than 200, there were 0 infections in those HIV uninfected partners. So let's turn now to talking about PrEP. And I'm going to start by talking about oral PrEP agents, then we'll talk about injectables, topical agents and multipurpose technologies, and then PrEP choice and rollout. So these are the IAS USA 2024 to 2025 recommendations for HIV PrEP. And you'll see that there are across the top, there are 5 columns, and those are the 5 types of PrEP that we currently have available. There's daily TDF-FTC, which is also known as Truvada. You can also take it on demand in a 2-1-1 method, and I'll describe that in a little bit. There's daily TAF-FTC, which is also known as Descovy. There's every other month IM injectable cabotegravir, which is also known as Apretude. And then there's an every 6-month subcutaneous injection with lenacapavir that's known as Yeztugo. What you'll see is that daily TDF-FTC is sort of the universal PrEP. It works for all types of exposures. And you can initiate it with a double dose in order to get the onset of action to be a little bit faster. It also can be used in pregnant and breastfeeding people. And if you look across the top, across all the rows, you can see that insertive anal and vaginal sex and receptive anal sex, you can use any of these methods for. For every other month injectable cabotegravir and every 6-month injectable lenacapavir, they've not been tested in people who inject drugs. The only drug that's actually been tested in people who inject drugs is TDF alone. But we think that it should work in that population based on PK, and people who inject drugs often also have sexual risks, so that would be a reason to treat them. And then the only reason you want to stay away from TDF-FTC is if individuals have a reduced creatinine clearance of less than 60 or have osteoporosis or osteopenia. So we've had TDF-FTC for PrEP available since 2012 when the IPREX study came out in men who have sex with men, and the Partners Prevention study came out in heterosexual serodiscordant couples, and the FDA licensed TDF-FTC for PrEP, and WHO also came out with guidance. But we knew from these early studies, there were early studies in women that looked like PrEP didn't work in that population, but it turned out that that was because of poor adherence, and there were a number of structural barriers to women taking PrEP in those studies. But you can see that if you take PrEP, it works. This is the effectiveness of PrEP compared to the percentage of participant samples that had detectable drug levels. And in serodiscordant couples, PrEP worked quite well for women. So it works, again, in all of these different populations, but it only works if you take it. So how much do you need to take? Well, we've for a long time said that cisgender men and transgender women had to take at least 4 doses a week based on the PK data and based on some modeling. But later modeling data suggests that even 2+ pills a week have a 99% effectiveness. So it's highly effective, and what we generally counsel men and transgender women about is you need to take it every day, but if you miss an occasional dose, that doesn't really matter. For women, the traditional thinking was that they needed to take 6 to 7 doses a week for maximal vaginal concentrations because of the PK, because it concentrates much less in vaginal than in rectal tissue. But model data suggests that 4 to 6 pills a week provided 88% effectiveness. So even if women are not able to be fully adherent to PrEP, they can still get a lot of benefit from it. And there were data from 11 demonstration projects of daily TDF-FTC in over 6,900 cisgender women, which showed that if they took 7 tablets a week, there were no infections. 4 to 6 tablets a week led to a 90% reduction. So again, even if women are not able to take PrEP completely on a daily basis, they can still get quite a bit of benefit from TDF-FTC. What about TAF-FTC? Well, this was first studied in men who have sex with men and transgender women. The eligibility required high sexual risk of HIV. This was done in 5,400 participants in North America and Europe with high HIV incidence. And the primary efficacy endpoint was HIV infection rates. And what you can see on the left are the week 48 data from that study, and on the right, the week 96 data. What you can see is that the FTAF, shown on the left, is a little bit lower than the FTDF rate of new infections, shown on the right, and that was true at both week 48 and week 96. But the confidence intervals really overlap each other considerably, and the confidence interval spans 1. So it's not superior, it's not better than TDF-FTC, but it's what we call non-inferior. So it means it's no worse than TDF-FTC, and we know that both TAF-FTC and TDF-FTC are about 99% effective in preventing HIV acquisition when taken on a daily basis. But what about women? Women were left out of that original study, and we had a really long gap where we didn't have any data on women. But lo and behold, in this last year, we've gotten data from the Purpose 1 study, which was studying lenacapavir subcutaneous every 6 months. But they put in an arm of FTAF, because this was a study in adolescent girls and young women taken every day versus FTDF taken on a daily basis. Now, the primary endpoints were lenacapavir versus background HIV infection rates and the FTAF versus background HIV infection rates. And they calculated the background rate of HIV based on participants diagnosed with HIV on screening. The secondary endpoints were comparing both lenacapavir and FTAF to TDF-FTC. So let me show you what they found. This is now data just on the TAF-FTC that we're focused on. And what you can see is that the incidence, the number of new infections in the FTAF arm, was not different from the background rate of HIV. But it also was not different from the background incidence of 2.41 in the TAF and the TDF-FTC. And we know that TDF-FTC works, so why did it not drive down infection rates in these women? And the reason, again, had to do with adherence. So the red bars here, this is showing the levels of drug over time, over 52 weeks of follow-up. The red bars mean less than 2 pills a week. The yellow bars mean 2 to 3 pills a week. And the green bars are 4 or more pills per week. And what you can see is that adherence was poor and it got much worse over time. So we think that it didn't work because women weren't able to take it. And so the Gilead did an analysis in which they compared people who acquired HIV who had been in the FTAF arm compared to people who didn't acquire HIV. And what you can see is that adherence was substantially poorer in the group who became HIV infected. The same sort of pattern, although a little better adherence, was seen in the men's study. And when they measured this, the odds of HIV acquisition were 89% lower among cisgender women who took at least 2 pills per week. So we know that FTAF works in women as long as they take at least 2 pills a week, and the efficacy is probably higher than 89% if they're able to take more than that. So which medicine do you prescribe for daily PrEP? We use this infographic that a colleague, Julia Marcus, created, which shows the size of the original TDF-FTC pill and the TAF-FTC pills. So you can see that it's a bigger pill. In terms of effectiveness, they're both highly effective in men who have sex with men and transgender women. In terms of women, we now have filled in that it's at least 89% effective if you take FTAF at least twice a week. The only data we have for people who inject drugs is FTDF. But in terms of safety, there's some small decreases in the GFR and in the bone mineral density in people who take TDF-FTC, but there are small increases in LDL and body weight for people who take TAF-FTC. And people who take TAF-FTC compared to people who take TDF-FTC were 3 times more likely to go on statins and 2 times more likely to have hypertension after adjusting for age. So there's a trade-off between them, and it really does require some informed decision-making on the part of the client or patient that you're counseling, as well as your knowledge of the situation. The big difference right now is that TDF-FTC went generic in 2020, and so it costs about $30 a month, as opposed to $2,200 a month without insurance in 2025 for TAF-FTC. What about 211 PrEP? Well, it's called 211. It came from the Ipergay study because you take 2 tablets 2 to 24 hours before sex, 1 tablet 24 hours after that, and another tablet 24 hours after that. So it's called 211. Could be called 21111 because you just keep taking daily pills until 48 hours after your last sex. And if there's a gap, but the last pill was taken within 7 days, you only need a single pill to start. The Ipergay results in their randomized control trial with a placebo found 86% efficacy for 211 PrEP. And when they compared in an open label extension, when people knew that it worked, there was 97% relative reduction compared to placebo. And there was no difference between daily and 211 TDF-FTC. So again, another really highly effective strategy. What about for women? Is there an on-demand approach for women? Well, we don't really know yet if there is or not, because as I mentioned before, tenofovir concentrates to a much greater extent in rectal tissue, shown in the red bars, than in the female genital tract, shown in green bars. And this is tenofovir diphosphate, which is the active metabolite of tenofovir. So, and this is a log scale, so it's a log or 2 less tenofovir in the female genital tract. FTC, the other part of TDF-FTC, actually concentrates to a greater extent in the female genital tract, but it's quite transient. And there are these data, we know that there's some difference between men and women because these are the data that I mentioned before, that only 2 to 3 doses a week can give you greater than 99% effectiveness in transgender women and gay and bisexual men. Whereas for cisgender women, you get about 90% effectiveness with 4 to 6 pills a week. So these are data that were presented at the Conference on Retroviruses and Opportunistic Infections, CROI, this year, in which they did a PK model and showed that if you had 211 in women and you looked at the female genital tract, 5 days after sex, you'd have 85% protection. And the protection was improved by 8 to 15% if you just added 1 more day. So if it was 2111. So what they are suggesting, and should be getting launched pretty soon, is a study in which we explore the efficacy of a 2111 regimen or another on-demand regimen for women. What about TAF-FTC? Can that be used for on-demand PrEP? Well, there's a study going on right now. It has a faster half-life and a faster time to peak dosage and a longer half-life. And so Jean-Michel Molina, who did the Ipergay study, is now studying 211 with TDF-FTC compared to 11 with TAF-FTC. So just one pill 2 to 24 hours before and one pill 24 hours later, which would be easier to manage. And so that's being studied in 524 men who have sex with men in France and Thailand, and we're waiting for results of that study. The latest oral agent to be tested is something called a nucleoside reverse transcriptase translocation inhibitor, or an NRTTI. Now, TDF and TAF are both NRTIs that have a single mechanism of action. NRTTIs actually have multiple mechanisms of action and are quite highly potent. They first started testing a drug called islatravir, and they were using it as a once-a-month pill. But unfortunately, the dose was so high that it caused reductions in CD4 lymphocyte counts. And so they're no longer pursuing a monthly islatravir pill. But there is another compound called MK8527. It doesn't exactly roll off the tongue, so hopefully they'll come up with another name soon. It offered complete protection in a non-human primate model, even at 0.1 milligrams per kilogram. And a single dose of 0.5 milligram in people living with HIV dropped the viral load by more than a log. So there was a phase 2 study in which 3 milligrams versus 6 milligrams versus 12 milligrams monthly was tested and found to be both safe and well tolerated and had no impact on lymphocytes or CD4 T cells. And so we're starting this summer 2 phase 3 studies, one in women and one in men who have sex with men, transgender and non-binary individuals. The women's study is in Africa, and the other study is a global study. I'm really proud to say that in San Francisco, we're the first site to get activated, and we're actively screening for this trial right now. And it's an efficacy trial to see whether or not it provides protection compared to TDF-FTC. So to summarize the oral PrEP regimens, we currently have 3 regimens. We've got daily TDF-FTC for all populations. We've got daily TAF-FTC for everyone except for people who inject drugs, but remember the PK suggests it probably works there, and people who inject drugs often have sexual risk. And then there's 211 TDF-FTC that's currently for cisgender men and transgender women, but we hope to have other agents in the future. The protection levels may be high for both men and women, even with less than daily adherence. And new approaches are being planned to be tested or are planned to be tested, and that's 2111 TDF-FTC in women, 11 TAF-FTC in men, and MK8527 as a monthly pill. And a monthly pill might really provide some additional benefit for people who don't want an injectable but want something that's longer acting. And it's something that you could potentially administer from a pharmacy or from a clinic. You don't have to carry around a bottle of pills all month. You could just take it once a month. So let's turn now to talking about injectables. The first injectable was cabotegravir. Cabotegravir is an analog of dolutegravir, so it's an integrase inhibitor. Its oral formulation has a half-life of 40 hours, but it's been milled into nanocrystals that have a half-life of 21 to 50 days when injected intramuscularly. This is the ad we used for the study HPTN 083, which was in men who have sex with men and transgender women globally. HPTN 084 was a sister trial in women in sub-Saharan Africa. Both of them had 3 steps. There was an oral lead-in period for a month because once cabotegravir is injected, it's non-dialyzable, you can't get it out. And so we wanted to be sure people were able to tolerate it. It turned out to be very well tolerated, and now we usually just go direct to inject. Then there was a loading dose at 0 and 4 weeks, and then every 8-week injections. And because it lasts so long, there's a tail of a year or so. People were given an oral agent to cover the PK tail for a year because the concern is that you get too low a level to provide protection, but high enough to select for resistance. Both trials were double-blind, double-dummy, with TDF-FTC as the comparator group. And this is what the two studies showed. This was compared to TDF-FTC. Cabotegravir was 66% more effective, so it was superior to TDF-FTC in the men and transgender women trial, and 89% better in the cisgender women trial. And why is that? Again, it has to do with adherence. It's hard for people to take a daily pill, and so coming in for bi-monthly injections was much easier for people. So can you improve upon that? Because getting people to come in every 2 months can be quite burdensome. So there are two strategies for less frequent dosing. One is to increase the volume and or concentration of the current formulation, CAB 200 milligrams per ml. And the second is to develop an ultra long acting formulation with a longer terminal half-life. So first they tested an increased volume of cabotegravir given subcutaneously with human recombinant hyaluronidase, which allowed for larger volumes of injection. But everybody had injection site reactions and the severity increased with the increasing dose, so they're not pursuing that approach. They've also tested CAB ultra long acting, both intramuscularly and subcutaneously. The half-life was more than 2 times greater for the intramuscular injection and 6 times greater for the subcutaneous injection than the original formulation. And so the injection site reactions were similar for the IM ultra-long acting versus the IM CAB 200, but the injection site's reactions were greater when it was given subcutaneously. And so they're pursuing the intramuscular injections. These are some PK simulations of the data, and what you can see in the red line is the every 2-month injections level, the levels in the blood in male sex at birth and female sex at birth. And in the black are the every 4-month formulation. And you can see that the every 4-month formulation was higher or equivalent to the every 2-month injection. So they have a trial called Extend4M, which is a phase 2b study evaluating the safety and PK of CAB ultra-long acting. It's going to evaluate the pharmacokinetics, safety, and tolerability of a new formulation. And the hope is that if the new formulation works and the PK looks good, then they don't need to do a full efficacy study to prove that it works. They're enrolling healthy individuals weighing at least 35 kilograms at 27 sites in the US and Puerto Rico and giving the CAB ultra-long acting every 4 months. But the latest kid on the block is the Science's 2024 Breakthrough of the Year, lenacapavir. Lenacapavir targets multiple stages of the HIV replication cycle. It's a novel capsid inhibitor where it works on capsid-mediated nuclear uptake, virus assembly and release, and capsid core formation. And this was part of the purpose. I already described the Purpose 1 study, which was in women, looking at lenacapavir, FTAF, and FTDF. They also did a Purpose 2 study in men who have sex with men, transgender women, and transgender men. And they were randomized just to either lenacapavir or FTDF because we already knew that FTAF worked. And again, the primary endpoint is compared to the background rates of HIV infection, and secondarily, how did it compare to FTDF? And what you can see is this remarkable result that there were no infections in the trial in women. That meant that there was 100% efficacy compared with the background rate and 100% efficacy compared with FTDF. And then there were 2 infections in the participants receiving lenacapavir in the men who have sex with men and trans study. And that translated to 96% efficacy compared with background rates and 89% efficacy compared with FTDF. So again, it was superior because it's easier to get an injection than it is to take an oral pill throughout the course of the study. But it doesn't come completely, it's not a complete free lunch. You do develop nodules, and the nodules are actually part of the way that the drug works because you're forming a subcutaneous depot. And about 2/3 of individuals do develop palpable nodules, and this is 2 injections into this subcutaneous space in the abdomen. And you can see that the yellow line is a grade 1 adverse event. The red line is the red bar is a grade 2. So most were fairly mild, some were moderate, and they were, you saw them both in the women and in the men and trans populations. They did seem to decline with each subsequent injection. There also was pain, and you can see the pain in the women's trial and the pain in the Purpose 2 trial. So the men and trans individuals had reported more pain than the women, and that's either because women maybe just were tougher, or it may be about body habitus. Because if you have a very thin body habitus, it's much more, anecdotally, it seemed as though it was more painful to inject into the subcutaneous space. It does help to ice first, and we learned that over the course of the trial. So the latest thing is actually a once-a-year lenacapavir injectable, and that would be given intramuscularly, so you wouldn't have these subcutaneous nodules. They tested 2 formulations. One was in 5% alcohol, one was in 10% alcohol. And what you can see from the green line for formulation 1 and the blue line for formulation 2 is that the levels were actually higher than the every 6-month injectable in both arms of the study. So this was a small phase 1 study. They still did have pain, and here we're looking at pain on days 1, 2, 7, and 15. And so what you can see is that the pain was predominantly in the first week and pretty much dissipated by the end of the week. Blue means no pain. Green means a little bit, hurts a little bit. Yellow means hurts a little more. Orange means hurts even more. And so you can see that there was pain in a number of people in both formulations of the study. But one of the things they did was for formulation 2, they split people into a group that got it without ice and a group that got it with ice. And you can see that with ice, it's substantially more tolerable. So CAB-LA has been licensed as a Q2-month IM injection, and it's being studied as a Q4-month IM injection. Lenacapavir has been licensed as an every 6-month subcutaneous injection. The IAS USA guidelines say that in addition to the abdomen and the thigh, which are the 2 sites that are part of the FDA label, that you can actually use the buttocks and the upper arm to give the subcutaneous injections as well, because the PK does support that. You need to ice people first, and it does leave nodules for an average of 10 months in women and about 12 months in men. So that is really of concern to a number of people. So Len is not going to be suitable for everyone. And they are now testing an every 12-month IM injection that also requires icing. So we're very excited to get started with that efficacy study. And for that study, they're just doing PK again so that they can, if they can show that the levels are comparable to what was seen with the every 6-month injection, then hopefully they can get licensure of that. So let's talk next about topical agents and multipurpose technologies. So the only currently available, and it's only available in Africa, dapivirine topical agent is the dapivirine vaginal ring. And the reason that it's not being licensed in the United States is that the efficacy was substantially lower than with the systemic products. But the effectiveness was actually over 75% at the highest levels of ring use. There were potential advantages for this. It was female controlled and discrete. There's limited systemic absorption for people who don't want a systemic agent. And there's no apparent antiretroviral resistance in breakthrough infections. So that's one strategy that has been tried. They're also testing now a 30-day vaginal film with dapivirine. And the advantages there are, again, ease of use and privacy. It's got a unique and convenient platform. There's no removal required. It's low cost, inexpensive to manufacture, and no applicator is required. And there's minimal to no vaginal discharge with that. There's also a TAF elvitegravir insert. Elvitegravir is one of the protease inhibitors, and it's a dual compartment insert that could be used vaginally or rectally for flexible, user-controlled, on-demand HIV prophylaxis. So again, something that's used topically for people who don't want a systemic approach to prevention. And it could be used just at the time of sex. We're also studying a tenofovir rectal douche. So it has several potentially desirable qualities. It's used on demand, so you only need to use it at the time of sex. It's topical for people who don't want a systemic product, and it's behaviorally congruent, which means that it's linked to an existing behavior, because a lot of people who are having anal sex do douche first, and so it could just be used as part of a routine. So it's being studied in the HIV Prevention Trials Network, HPTN 106, versus a 2-1-1 oral regimen for safety, acceptability, and product preference. And there's a PK sub-study and also an ex vivo study to look at its anti-HIV effects. And then what about multi-purpose technologies? Well, those provide protection not just against HIV, but against contraception, STIs, or both. And then there are also MPTs that look at contraception and STIs together. So the furthest along in development are a dual prevention pill using an oral contraceptive with PrEP. There's a 90-day vaginal ring using dapivirine and levonorgestrel, a monthly vaginal film using those same products, and a TAF elvitegravir doxycycline insert that would protect against bacterial STIs as well as against HIV. Let's talk next about PrEP choice and rollout. So why do we need all of these products? We now have so many different products, and why are we testing more? Well, we know from the contraceptive literature that increased choice was associated with increased contraceptive uptake, increased persistence on the chosen method, and better health outcomes. And there was a 4 to 8% increase in contraceptive prevalence for each additional method that was used. So giving people choice really helps people to choose what's going to work best for them. And similar to contraceptive needs, different people have different HIV prevention needs at different times. And this was probably best shown in the SEARCH trial from Kenya and Uganda, in which they enrolled adults and they randomized them either to choice of PrEP or PEP, along with other support services, versus referral to their local Ministry of Health clinics. And they had choice of cabotegravir as well as oral PrEP and PEP. Overall, you can see the blue bars is the amount of time that was covered by one of the protective agents, and it was about 70% in people in the dynamic choice arm, and about 13% in the people who had standard of care. The HIV incidence, the HIV infection rate, was 0 in the group that had dynamic choice versus 1.8% per year in the group that had standard of care. And you can see that not only was CAB-LA uptake high, 56%, but 28% took 2 or more products over time. So people want to be able to switch and use what suits their needs at the given point in time. And then why does it matter how many people we get onto PrEP? Well, this is some data from an elegant analysis done by colleague Patrick Sullivan, in which he took the 50 US states and divided them into groups of 10, 5 groups each, and looked at what was the mean PrEP coverage by PrEP quintile of use from 2012 to 2021. So it varied anywhere from 6% of people who might benefit from PrEP over that 10-year period versus 15.7% in the highest quintile group. And in Washington, D.C., it was 24%. And then what he did was, after adjusting for viral load suppression rates in those states, he looked at the annual percentage change in HIV diagnoses. And you can see this kind of dose response curve where District of Columbia had a 10.8% decline per year in the number of HIV diagnoses. In the top quintile of states, it was a drop of almost 5% per year, as opposed to an increase of 2.4% per year in the places where PrEP was rolled out least. So we do feel that PrEP is having a population level impact. We also want to know that we're getting PrEP to the right people, the people who might benefit from it most. And I've shown you the racial and ethnic disparities in terms of the numbers of new diagnoses. So the fact that we have fairly equivalent uptake in 2024 across the different racial groups doesn't take into account that we have many more diagnoses per 100,000 population among Black and Latino individuals. And so you can calculate something called a PrEP to need ratio, where you divide the amount of PrEP that's being given by the number of new diagnoses in that subpopulation. And you can see that white individuals are doing much better over time than either Latino or Black individuals. So we have a lot of work, again, cut out for us to make sure that we get equitable rollout of these drugs. We also know that we're not reaching people who inject drugs. These are some data from the National HIV Behavioral Surveillance Study in 2018 and 2022 that was conducted in 19 US cities in HIV-negative people who inject drugs. PrEP awareness did improve significantly from 2018 to 2022, but it only went up to a little over a third, and that's 10 years after PrEP was licensed, and only 1.2% in each year were actually on PrEP. So we know that we've got, again, work to do in trying to get PrEP out to people who inject drugs. And then these are some trends in oral and injectable PrEP prescriptions. The top line just shows the total number, so you can see that it's been increasing year over year. This line is the branded TDF-FTC. This is branded TAF-FTC, and sorry, this was branded TDF-FTC. This is branded TAF-FTC, and this is generic TDF-FTC. But you can see cabotegravir is only 2.5% of all of our new PrEP prescriptions. And so we've had a really rough time rolling out cabotegravir, and it should be a breakthrough for us. And so we need to find better ways to roll it out. Persistence on PrEP is also an issue. PrEP persistence rates are a median of less than a year, and they're significantly lower in publicly insured and uninsured people, women, Black and Latino people, and younger individuals. And HIV incidence is substantially higher after stopping PrEP, and that was shown in both LA and San Francisco, but in many anecdotal studies, and most of the people in these studies did not speak to a provider before discontinuing PrEP. So people stop PrEP for all kinds of reasons. It can be insurance or cost, but it can also be that they no longer consider themselves at risk. Sometimes that's true and sometimes it's not. So it's really helpful if people are going to go off PrEP that they receive some counseling about it. So let's turn to talking about post-exposure prophylaxis briefly. There are new CDC guidelines in 2025. They're now recommending a 3-drug regimen with that you take within 24 hours, but up to 72 hours after exposure, but the sooner the better. And the new recommendation is for a drug called Biktarvy or Bic-Taf-FTC, because it's a single pill, and it's been recommended by IAS-USA and now the CDC. There's something called pill in pocket, which is helpful because you can prescribe it for people who may have exposures so that it can be started as soon as possible after an exposure without having to go find a provider to prescribe it for you. WHO guidelines emphasize demedicalizing the settings, and pharmacy is available in some states. In the green states, it's available, and in the yellow states, it's being considered that pharmacists could prescribe it. But you can see how we're doing this is how we're doing with PrEP prescriptions, and this is how we're doing with PEP prescriptions. So we really haven't made much headway year over year, and it is a tool that we do need to be able to use to drive down infections. So we'll close by talking about monoclonal antibodies and vaccines. We have over a 100-year history of antibodies to prevent infections through passive immunization, all the way from tetanus in 1890 and all the way to SARS-CoV-2. We had a proof of concept trial called the AMP studies. These were 2 sister trials, one in men who have sex with men and transgender individuals, the other in women. And they showed 76% protection against acquisition of highly neutralization-sensitive viruses. The challenge was that a lot of the viruses were not neutralization sensitive. It was safe and well tolerated, but we probably need a combination approach. And so what's next is something called Combo AMP, which is combining 3 bNAbs to to increase the prevention efficacy. Each bNAb targets a different part of the HIV envelope. You can see them here. potency and breadth are greater than with a single HIV nab alone. It may limit early viral escape. And so we're targeting the CD4 antibody site and the V2 and V3 loops. And LS mutations allow administration only every 6 months. And then finally, vaccines. We're 42 years into the epidemic and we still don't have an HIV vaccine. So why is that? Well, HIV is hypervariable and there's ongoing replication, and it's what I call a sloppy virus. It makes mistakes all the time and does not autocorrect. Once HIV infects, it maintains persistent infection for life. There aren't examples of natural clearance of infection, and so we don't really know what the target is. HIV evades, avoids, or escapes antiviral antibodies and T cell responses. It attacks and directly infects key immune effector cells. And the common animal models have uncertain value in reliably predicting the efficacy of vaccine candidates in humans. So we probably need vaccines. We've been developing vaccines that generate non-neutralizing antibodies. We probably need vaccines that generate neutralizing antibodies. And we'll also need vaccines that produce cell-mediated immunity. So the HIV Vaccine Trials Network is the world's largest publicly funded international collaboration for HIV vaccines. The focus is shifting to discovery medicine rather than traditional phase 1 trials. The goal is to test hypotheses rather than to test products. So we're trying to generate broadly neutralizing antibodies with these vaccines through streamlined, shorter protocols with more in-depth lab assays. And it allows quick iteration, particularly with the mRNA platform, which can be manufactured quickly. And this is just the discovery medicine pipeline. We went from 8 trials over the last 2 years to 9 trials this year to 14 trials planned for next year. So in summary, treatment is one of the most effective prevention tools we have. We've got to remember about U equals U. Daily and on-demand oral PrEP regimens and injectables administered as infrequently as every 6 months are currently licensed in the US, and the pipeline of new products is robust, but access and disparities in rollout are issues that need to be resolved. PEP is an additional important prevention tool and needs increased awareness from providers and potential users and easy access. Combination broadly neutralizing antibodies are entering testing and efficacy trials are in planning. And vaccine research is currently focused on eliciting neutralizing antibodies, and there are a lot of promising approaches currently under development. So with that, I want to remind you to scan here for your CME credits, and I'm happy to take questions. Thank you.
Questions?
I'll say it again, you're a tour de force, and it's really amazing to learn from you. If we go back to the lenacapavir work, you'd mentioned that there were 2 breakthroughs or 2 infections. Do we have any sense of why, and especially as we're counseling patients on their risk, what was the context behind those 2 infections? And how do we counsel them of lowering their risk even further, I suppose?
Yeah. So the 2 infections that occurred did have resistance to lenacapavir. So it may be that, again, it's selected for resistant virus, and they had fairly high viral loads with the breakthrough infections. There have been 2 more infections in the women's trial and 2 more infections in the men's trial since the studies closed, because they've been open label extensions now where people have been able to get them. We don't yet have the resistance typing for those viruses, but it's likely a matter in part of resistance. We think that they had adequate levels of lenacapavir.
Thank you for that. You mentioned that post-exposure prophylaxis is available in some pharmacies across the United States. It seems like access to PrEP is certainly something that needs to be addressed, especially with 211 or 2111. It's not an ongoing medication. Is there work ongoing that makes that available in pharmacies, on demand, virtual health? What are the efforts that are going into making that available and accessible without a physician's prescription.
Yeah, so there are states that in California, we have the ability, it used to be that pharmacists could only prescribe PrEP for a month, but now they can prescribe it on an ongoing way. So there are states that do have pharmacy driven PrEP. And then there's teleprep that's being used quite extensively. I understand that Mister has over 500,000 people on PrEP using telehealth. So there are other strategies to try to really roll out PrEP on a larger level. The challenge is that that's probably, like teleprep works for oral PrEP, but not for injectables. That's why it would also be nice to have a monthly pill that could be taken.
So once yearly lenacapavir seems like one of the most exciting things, especially if the local side effects can be controlled, and it seems like that's a solvable problem. So how soon should we expect efficacy data for once yearly len, and are any starting to dribble out yet?
Yeah, we're supposed to be launching the trial any day. It hasn't started yet, but it will start this fall. And it'll probably be a year's worth of follow-up. So it'll probably be 2027 when we'll have lenacapavir as a monthly injection, as a yearly injection, hopefully, that it would get licensed. So what they're hoping is that all they need to do is actually show the PK is equivalent to over the course of the year, compared with every 6-month lenacapavir. And that would allow them to license it without having to show that they actually have driven
Oh,
down
right.
new infections.
And are there multiple trials, or is there one big trial?
There's one trial in 300 individuals. So it's not a huge trial. These other trials, large trials, have been like 5,400 people.
Thanks again for your visit. As I think we both know, there's a fallacy in the US that HIV is completely controlled and not a problem for anyone anymore. And of course, it's a problem in particular for people who are in the shadows or who don't have access and so aren't recognized. Clearly, Len is the breakthrough of the year. And but could you comment on how we are going to make Len available for individuals either in resource-limited settings or in the resource-limited settings in the US to realize its potential?
Yeah, great question. So what I will say is that ViiV rolled out cabotegravir very slowly, and Gilead is really trying to work on rolling out lenacapavir very quickly. There are questions about benefits and whether or not private insurance is going to cover it. My understanding is that CVS just decided it would not, the CVS, not the pharmacies themselves, but the higher level decided they would not cover it because it's not yet authorized by the USPSTF, which of course is ridiculous because it was just licensed. So hopefully that will change soon. They do have a patient assistance program that is working, and it can be covered in some states by Medicaid. But we do need to do a lot more work to actually do outreach to people who need PrEP, who may not recognize they need PrEP or may not think that it's available to them. And in resource-limited settings, it's really problematic. It costs here $28,000 a year. And in resource-limited settings, they have licensed it to, it's easier to produce than cabotegravir, so it should be able to get rolled out in a generic way in resource-limited settings more quickly, but it's a limited number of resource-limited settings where that's being done.
We have a question from the chat.
Comment and question from the chat. There's a plug. There's a similar initiative to SF's Getting to Zero in Denver called 5280 Fast Track Cities Task Force. And then kind of along those lines, the question is, how do you maintain momentum and funding for your Ending the Epidemic Collaborative? It's been a challenge for us without dedicated funding or staff.
Yeah, it's really is problematic. We're fortunate in that this health department has funded one position for our Getting to Zero effort, which is a coordinator that really helps keep us moving forward. The rest of the 300 members, 300+ members are all volunteers. And what we try to do is we've got committees that work on specific topics like PrEP or rapid treatment rollout or people experiencing homelessness or aging in HIV. We've got different committees dedicated to each of these different topics as well as several others that meet on a regular basis to keep the momentum going forward. But I will say that having a coordinator has really been critical for us in helping to keep the momentum going. And then we have 3 times a year, we have meetings for the entire consortium in which we try to handle a thorny problem. And right now, in September, we're going to be talking about PrEP for women and people who use drugs.
Thank you, Susan.
Thank you.